Hi, my name's Joe Bellick, and I'm the founding partner of the law offices of Bellick and Fox. We support the mesothelioma community by providing first quality legal representation to mesothelioma patients and their families. We're proud to support the Mesothelioma Applied Research Foundation so they can continue the work that they do every day on behalf of mesothelioma patients and their families.
At MRHFM, we exclusively help mesothelioma patients and their families. It's all we do.
This is why we are proud to sponsor the Mesothelioma Applied Research Foundation and its work to fund mesothelioma research and provide support services and education for patients and their families.
Thank you all for joining us on this episode of MesoTV. I'm happy to welcome Dr. Jacob Strand from the Mayo Clinic. Dr. Strand is here to discuss some common myths and misconceptions around palliative care. Could you please take a moment to introduce yourself and share your role at Mayo Clinic?
Yeah, absolutely, Julie. Thanks so much for having me today. So my name is Jacob Strand. I am a palliative care physician. I actually run our palliative care program here at Mayo Clinic and spend most of my time taking care of patients with cancer, including patients with mesothelioma in our outpatient palliative care practice, as well as seeing patients who end up getting admitted to the hospital with a variety of symptoms and needs, and so see them in both those locations. And then I spend a lot of my time doing research work with our colleagues in the Cancer Center to try to help advance the practice of symptom management and quality of life care and other supportive cares for patients with cancer. So I'm delighted to be able to chat about palliative care today with you.
Awesome. So let's jump right into this important topic of palliative care. There's many misconceptions around palliative care. People mistakenly equate it with hospice care. Could you help clarify the distinction between palliative care and hospice care? People often hear the word palliative and they think end of life, or they're no longer being actively treated.
Yeah, no, thanks, Julie. It's a really important question. And it's something, as you can imagine, for someone like me who's been doing this for about a dozen years, get that question all the time, and really a normal thing to wonder about. And some of that is because palliative care, at least palliative care in the United States, really emerged out of hospice and really emerged not only out of hospice, but also from oncologists or cancer physicians who were trying to find additional ways to care for patients with cancer and with symptoms that were affecting their quality of life. So as we've seen the growth of palliative care, the most important thing that's happened really over the past 20 years has been the emergence of palliative care as a specialty of medicine that is really aimed at helping patients with a serious illness at any age or at any stage with their quality of life. And I think that's the number one take home, is that this is really for patients at any point in their cancer journey to provide additional support. We often talk about providing an extra layer of support as a way to help patients navigate that journey through cancer. Now, that might mean managing physical symptoms like pain, nausea, shortness of breath, difficulty sleeping. It might be addressing those concerns that often come up when folks are faced with a serious illness like cancer: anxiety, depression, grief, also just worries about themselves and their family. And part of our job in palliative care is to partner with a patient's oncologist and treating care team, whether that's just their oncologist or their oncologist and their primary care provider, to do whatever we can to manage those symptoms affecting quality of life and to be an additional form of support. And not just for the patient who's going through this, but also for that patient's caregiving network to be a support to them. And so that model really has moved from seeing a lot of patients who maybe didn't have treatments left for their cancer or for their mesothelioma to really moving up to patients who might just be diagnosed with that diagnosis and might be dealing with shortness of breath or pain. And it's very common now at centers who have large palliative care programs to bring in a palliative care team as a partner to help manage that care. And I think that I say all of that, which is to say that not that hospice isn't important, because for those patients who are at that time in their life where they need help with end of life care, and that's the right time for them to access those resources, it can be really critical for patients and their loved ones to have those resources. And for us in palliative care, we're really focused on helping patients, really even again, very beginning phases of a diagnosis of mesothelioma, to walk through that, sometimes with a lot of support, sometimes pulling back because things are going really well, but always as a partner in managing symptoms affecting quality of life.
Yes, yes, and that's very important. Some studies I have read even show that integrating palliative care soon after the cancer diagnosis can enhance the quality of life for the patient, their mood, prolong their survival. Patients have better outcomes. Isn't that true when they start palliative care soon after they're diagnosed?
Yeah, thanks, Julie. That's a really important piece, is the difference between getting palliative care involved, sort of later on or at the end, versus this really intentional plan
Yeah.
for having palliative care as part of the care team, like the oncologist, like the, cancer nutritional support team, like, the physical therapy folks, or, anyone else who might be helping manage a patient with mesothelioma really early on. And that's because what we have found, as you noted, what we've found for quite a while now in a number of different studies looking at a number of different cancer diagnoses. And I'll just note that the best evidence is actually in patients with lung type cancers, but certainly across multiple types of cancers, we found that absolutely early palliative care involvement is linked to patients having a better quality of life, period, full stop. Additionally, which is really, I think, important, and sometimes we miss this part. Certainly, patients don't, but we as clinicians sometimes miss this. Is that early palliative care involvement in patients with cancer also has significant benefits for their caregivers, including things like less emotional distress for their caregivers, and again, better function overall for that patient and their family unit. So we really find that to be a critical part of care for patients with cancer, is to have access to palliative care early on.
Mhm.
What I'll add to that, which is really important, is that doesn't mean that you're going to lose out on visiting with that clinician or that care team who's really your quarterback, right? If it's the mesothelioma team, they're still calling the shots about how we manage care. And we're really a specialty who is there to provide that additional layer of support. And that can take many different forms depending on how someone is doing. And I think that's the beauty of it, is that we can really be patient focused, caregiver focused, and dial that in based on what they need.
That was actually my next misconception,
Yeah.
so to speak, that a lot of people are afraid if I get sent or referred to palliative care that I'm sort of sent out to pasture. I'll no longer
Right.
see my primary oncologist. I won't get active treatment anymore.
Hmm.
So I think you were actually shedding light on how palliative care coordinates with the primary oncologist. Yes.
Yeah, and I love that term, that maybe just to add to that, which is really important, this idea of active treatment, which is
Mhm.
really, I think, something we hear a lot from patients, is this worry
Yes.
about, well, I'm still getting active treatment. Is it okay to also have palliative care? And what I would argue is that treatments for cancer are designed to help people live as well as they can for as long as they can with the best quality of life. Maybe that's something that we can cure. Maybe it's something we can turn into a chronic disease and help people live for a much longer period of time.
Mhm.
And those tools might include surgery, or they might include, a drainage tube in the lung to remove some of the fluid that can come with mesothelioma. It might be chemotherapy or immunotherapy or new clinical trials. And it also is pain management and physical therapy and good nutritional status. So those are all tools that we use when we think about a holistic form of care for patients. And they're all active forms of treatment. And so I think that's the other piece that is really important, because we also know for patients with cancer that those who have a better quality of life, a better functional status, and less pain actually do better with their cancer treatments and live longer as well. So really important that we think of that holistically.
Yes. Speaking about misconceptions,
Yeah.
another big issue and an issue that a lot of mesothelioma patients do have can be pain.
Yeah.
When it comes to pain management, I know this is a very important aspect of palliative care and one that's handled very well by palliative care, patients tell me. Patients I know all have an issue where they state they're afraid of getting, quote, addicted to pain medications. Can you talk a bit about how palliative care deals with pain management and why palliative care is so well equipped to handle this?
Yeah, thanks, Julie. That's a really important topic because again, it's one of the biggest barriers that I run into in working with patients and their families is how do we balance really the benefit of any treatment with any of the potential burdens or side effects? And certainly, particularly in this day and age when we're living with day in and day out information about the opioid epidemic
Yes.
and the challenges that that has caused for so many patients and families, it's critical that we understand the role of stronger painkillers like opioids, but also that we put it in the context of what we're really trying to accomplish, which is we're trying to accomplish better pain control, not just for a number out of 10, but really what does that mean for someone's ability to function and live well with their quality of life? And so opioids are those stronger painkillers that can have that risk of addiction are one tool in that big strategy. So I think that's one thing that I always try to explain to patients is that having pain doesn't mean all of a sudden we're prescribing high doses of these medications and putting you at risk for addiction. It means that we're going to look at all the different options that we have in our, really all the tools that we have in our toolbox to help manage pain. And when we do think about opioids and we do think about other medications that can have risk of addiction, we really think thoughtfully about number one, is that the right medication for the patient? Of those medications, which one do we choose that might have different risks? What does each patient bring to the table? Everybody comes to the table with different backgrounds and experiences and risks that they may have for addiction as well. And so we think about how can we create a plan and really surround that patient with as much safety as possible. I have had patients in my practice, and I have many patients in my practice now who have a history of addiction, and that might be addiction with alcohol or with painkillers in the past. And we talk about this very openly about, what is that risk to you? What are you worried about? And thinking about managing your symptoms with some of these stronger medications. And then if we are going to prescribe them, we really have to think through that close monitoring because part of our job is also to make sure that that a patient is using those medications as they're intended, and that also we're not developing some of those risk factors or warning signs that maybe this is a medication that's now being used unsafely. And so that's a really important conversation more than anything else with the palliative care team. That is important to bring patients in and be open and honest about how they're feeling. And I think what we've learned as a team over the last 10 to 20 years is that we actually have a really important responsibility in safe use of those medications, and that when we have a team involved, that I think we can do that and really manage that safety and help provide safe care for patients.
Well, that's great to hear. I know you touched on this before, but some of for patients with mesothelioma, some of the common symptoms that they experience are, as you were saying, the shortness of breath, dyspnea, cough. There's also diarrhea, constipation, nausea, weight loss, anorexia, the fatigue, and of course, anxiety and depression. Could you share with us how palliative care helps with these types of symptoms?
Yeah, great question, Julie. Because that really we feel in palliative care is one of the foundational elements is to think through with a patient what are those symptoms that they're experiencing either from the cancer itself, from the treatments we're giving for the cancer, or frankly, a lot of people are coming and get diagnosed with cancer who have problems that came even before they were diagnosed with cancer, but they take on different meanings. Sometimes treatments can actually make those worse. Sometimes they can become more prominent because people aren't able to move around as much. So really that holistic look at pain and other symptoms that are affecting quality of life is one of the most important things that we do when we're first meeting a patient and when we're watching and walking through them, walking with them through their treatments. So that's the first part. The second piece is to that is really thinking through how do we do this as a team. So for example, when I work with our oncologists who are managing patients with mesothelioma, we are talking together about, all right, who's doing what here? Who's going to manage the pain? Who's going to address these issues? And often my oncology friends and colleagues say, you know what, we know that this might happen because of this treatment, so we'll watch out for this piece if you can do this. And so that's a big part of the role that we play is really helping to provide that team-based approach to a patient's care so that we're all looking out for the parts that we can be most helpful with. I also have patients who, I've gotten to know them so well. Over the last months and years that I sometimes see things before their oncologist sees them because of that relationship and because of how close we might be following for something else. And so I think an important part to explain to folks too is that while I might manage something or our team might manage something, we're also going to communicate that to our oncology colleagues so that they know what's going on and that how it might affect treatment. And I think that is something that's really important, is to have that open lines of communication. And then maybe the last piece I'll share about this is that if you're involved with palliative care, I think it's really important that it's not just one person. There's certainly somebody who is a point person, but that part of palliative care is to have physicians and nurses and nurse practitioners and pharmacists and physician assistants, chaplains, social workers. We're really fortunate here at Mayo Clinic to have additional resources like integrative therapies, Reiki and massage therapy and acupuncture. And so all of those are, again, things we might call upon to be team members to help manage a patient's symptoms. Because again, people respond to different things, and we want to make sure we're pulling all the levers to help folks improve their quality of life.
Sounds like there's a lot of options, and that, excuse me, you also work very well with their primary oncologist to, keep each other in the loop, so to speak, or informed as to what's happening. So that's
Yeah,
good.
I think that's critical, and I think that
Mhm.
that to be honest, that doesn't happen everywhere. I think we
Right.
have I think this is still a field that is growing, just as I think we're understanding more and more about mesothelioma, the disease, and how to best care for it. We're also learning how to best integrate practices with palliative care and oncology. And so I think for patients who might be watching this and listening, really asking those questions about how do you work well with these other teams, and that not just us, but also the other specialists that would be involved in care of a patient are really important.
Yeah. Um, this dealing with the symptoms sort of leads to another question I had, which is, it seems like with palliative care, it can be helpful at different points in the patient's treatment journey, such as dealing with, and maybe in the beginning when they're diagnosed with some of the psychosocial issues they have, anxiety, depression, maybe getting pain under control, and then later maybe in advanced disease, you can deal with things such as cancer-related fatigue or anorexia. So it seems like palliative care can be an ongoing journey that follows the patient throughout, which again would be a misconception that it's the end of life care, but it seems like
Yeah.
from what I'm learning that it's a good co-partner with the oncologist throughout the patient's journey, and at different places it has different uses. Is that correct?
Yeah, no, that's right, Julie. And I think a part to that that's really important is that ability to adjust the dose or the frequency of palliative care
Mhm.
based on how someone's doing. And
Right.
so a really common practice that I see both here at Mayo Clinic, but also when I talk to my colleagues at other institutions, is that when a patient has a new diagnosis of mesothelioma, often there are a lot of symptoms up front, and so we're managing whether that's pain or shortness of breath or nausea with new treatments. Those are things that we might get really involved in early on. And some of my favorite visits are when things are actually going pretty well and we're kind of stable and we're smooth sailing. Our visits are more like high five, you're doing great, you had a great response. Instead of following up in a month, let's follow up in 3 months. But here's my phone number because if something changes, I want to know about it so we can see you again. And those are things that then again, if something changes, if there's a new treatment being used or a clinical trial or a new surgery, that we might want to get re-involved more frequently to
Mhm.
help provide support. The other thing, and this is kind of the flip side of that, which is sometimes folks might get diagnosed and it's a huge shock because they feel fine and they're like,
Mhm.
how am I going through this diagnosis of mesothelioma when overall I'm doing okay? And that's still a time where I think it can be very valuable to meet with a palliative care team. And the reason why is that some of this is also about developing relationships and thinking through ways to help people cope with a new diagnosis. One of the pieces we're learning about in a number of different research studies that have come through in the past 5 years and that are ongoing even now, is that how people cope with stressful situations can often be really important in how they experience things like depression and anxiety, difficulty sleeping, and relationships with their loved ones.
Yes.
And so that's some of the things that we do, is to work with patients on developing different coping skills or new coping skills, and helping support those coping skills as other tools in their own toolbox, really empowering them to be able to have those tools to help manage symptoms related to their cancer, and also some of the distress that can come along with a new diagnosis. So again, even if things are going well, maybe from a physical side, it can be beneficial to meet with somebody and, even talk through a few of those options before, again, having a journey that might be frequent visits, or it might be more intermittent as someone goes through that journey.
Certainly. When you mentioned loved ones, excuse me, that made me think of a misconception that I did read, that people believe that palliative care is just for the patient. Does it
Yeah.
not extend support to the families as well?
Yeah, that's a really important piece, and again, a piece in a lot of the research studies that have come out in the last 5 years that have really focused on how caregivers are going through that journey and how loved ones are going through that journey. Because we know, and I hear this from patients all the time, that not only could they do they find so much benefit and support from loved ones, whether it's getting them to visits, taking notes when they're in the room, asking questions with them, helping them with medications, being the person to come over in the middle of the night when something's not going well. We know that for a lot of people who have that type of support, it's so important. And at the same time, one of the biggest worries I hear from patients is, I'm worrying I'm being a burden on the people that I loved. So I think what we try to do within a palliative care team is to be a resource, not just for the patient going through this, but also the people who that patient identifies as their caregivers and their loved ones. And that might be simple things like just being able to listen. That might be again, a resource when something is happening and they need some answers, or they have some questions about a symptom that's come up, and also just talking through the stresses that they might be experiencing. So we spend also a lot of time trying to help provide support for caregivers and loved ones. And interestingly, there's a new study that and there's actually several studies, but one study that we're involved with here at Mayo Clinic, both in Jacksonville and here in Rochester, is a study specifically designed to support caregivers of patients with a serious illness. So I think we're learning more and more just how important it is to be holistic, not just with what the patient is experiencing, but also with their loved ones and caregivers.
Yes, caregivers are an important part of our community here as well.
Yeah.
Do you have any advice for patients to prepare for and make the most of their appointments when they come to see a palliative care provider?
Oh, that's a great question. I think a couple of things come to mind that I, always ask my patients to make sure that we're getting at, which is, what are the one or two or three most important things that they want to accomplish with that visit? And that might be, why the heck am I here visiting with palliative care? Just kind of understanding more about what the resources are. I think that's a great first question. Now, if you've watched this video and you sort of now know what palliative care can do, a couple of things that are important: trying to think through what are the physical symptoms that are impairing quality of life for you and your function. And then I think the paired piece to that is, what does good function look like to you? Because everybody has a different level of what's important to them.
Mhm.
And thinking through, if it's pain or shortness of breath, gosh, if we could get that down by 50%,
Yeah.
what are the things that you would like to do? What would you be doing so that we can look ahead in a month and say, hey, we were successful? So I think that's important. It's just brainstorming some of those pieces about what feels like the most important aspects to focus on, and then what are the symptoms that are really most affecting your quality of life. I think another question is just what we were talking about caregivers and loved ones, is what resources do you have for my family, and do you have any other thoughts on where we can find additional resources? So I think that's really important.
Helps
And then
kind of get a picture.
yeah, absolutely.
Mhm.
And then I think the third question is really it's about accountability, which is, how are you, meaning the patient's talking to me, how are you going to work with my oncologist to make sure that we're all working together? I think that's a really good question. And so I usually tell people that because I know the oncologists who treat mesothelioma here at Mayo Clinic really well, I have no concerns about picking up the phone, sending them an email, sending them a page, and trying to understand those questions. And not, that's obviously going to be different at different institutions, but just understand what that relationship looks like, I think, is important.
Yes. Is there anything else that you want to mention that I may have missed?
Oh, well, you asked a lot of really important questions, and actually things that I ask patients, prompt those same questions when we're visiting, getting to know each other. I think the other piece that I think is really, really important to be able to share and make sure this comes across is, a few things about what makes you as a patient, who you are, that are important for your care team to know to take the best care of you. And that's a question that I love asking, because it gets sometimes away from all the medical questions we're asking, and it really gets to some of the important pieces that make someone who they are. That might be their loved ones, it might be their faith community, it might be other religious, spiritual, or cultural practices that are really important for us to understand, so that we can help take care of you, not just as a person with a diagnosis, but really as a person who's experiencing a serious illness and needs to be treated as an individual. So I think a couple things are examples of who you are that can help us take the best care of you possible is really important for us to know.
Yes. Well, I want to, excuse me, express my gratitude, Dr. Strand. Your insights have been invaluable, highlighting the significance of palliative care in the patient's journey. I really thank you for being with us today. And this has been just a great help, and I'm sure that it's going to be very useful to our patients, and I thank you.
Yeah, thanks, Julie. I also just would say back at you, which is that when I work with patients, having groups and foundations and patient advocacy and caregiver advocacy groups are so important in providing support for people, and also just a venue to learn more information. So thanks for letting me be a part of that today.
Thank you.